I'm a fifth year medical student, and in today's lecture we shall be talking about intussusception. To begin with, beginning with the definition, intussusception is just the telescoping invagination of an intestinal segment into the lumen of the adjacent segment. Or we can also define it as a condition in which part of the intestine falls into the segment next to it, and it is usually involves the small bowel, and rarely does it affect the large bowel. Going into deeper, intussusception can be divided into two. We have one without a leading point, and we have one with a leading point. So what are we calling a leading point? In simple terms, a leading point is a lesion or a variation in the intestine that is trapped by peristalsis and dragged into a distal segment of the intestine, calling intussusception. So in simple terms, any variation or lesion in the intestine that can be trapped by peristalsis can lead to intussusception. And we have many things that can act as our leading point. It can be Meckel's diverticulum, it could be a polyp, it can be a tumor, or we could have vascular malformations. Going into the demographics, this is the most common acute abdominal disorder in early childhood. In simple terms, it is the most common cause of intestinal obstruction in early childhood, and it affects boys 4 times more than girls, and majority of the patients are between 3 months and 3 years, with the peak incidence being between 5 to 9 months, and 75% of the cases are those under 2 years, with seasonal peaks in the spring and autumn. 95% in 95% of the cases there is no pathologic lead point, while 5 to 10% we have a recognizable lead point. In simple terms, the main marking point here that in 95% of the cases we really don't see any pathology. We don't see any pathological leading point. Going into pathogenesis, intussusception affects mainly the ileocolic. That is between 75 to 95% of the cases occur in the ileocolic region, followed by the ileocolic region, and then the ileo, and then the colocolic, uncommon. Also, we have the gastric intussusception, which is extremely very rare. The intussusceptum is a proximal segment of the bowel which invaginates into the intussuscipium, which is the distal segment, dragging the associated mesentery with it. After this, we shall have development of venous and lymphatic congestion, with resulting intestinal edema, which may lead to ischemia, could lead to perforation, and patients could come with features of peritonitis like guarding, abdominal guarding, or abdominal rigidity. This is a drawing showing part of the ileum telescoping into the cecum. Telescoping into the cecum, we said when we have intussusception, we have blood vessels will become trapped between layers, and blood flow will be decreased, leading to edema, strangulation of the bowel, could have gangrene, sepsis, and shock. All these happen if we don't intervene within a short time as possible. And again, this is another diagram showing an intussusceptum telescoping into the intussuscipium. We shall see that as time comes. So when we look at the causes of intussusception, we shall split them into non-pathological lead points, which comprise of majority of the cases, then the pathological lead points. Then under the non-pathological lead points, we have the viral causes like the rotavirus, the adenovirus, then the human herpes virus 6. Then we have the Shigella, the Yersinia, the Peyer's patches, hypertrophy. All those comprise of the non-pathologic lead point. Then we have the pathological lead point where we find Michel's diverticulum. It could be polyp, it could be lymphomas, it could be any other tumor, it could be cystic fibrosis or a foreign body. And again, this is another diagram showing part of the ileum, the distal ileum, telescoping into the cecum. And the clinical presentation is really variable. Patients, mainly who are children, will be presenting with intermittent colical cramping pain. Later, there is a development of lethargy and somnolence. It will come with vomiting, which is mainly bile stain, because mostly the obstruction is really distal. That's why we have the bile stain vomiters. Then they come with the curry jelly stool. In simple terms, we will have blood in their stool. Then presence of a sausage-shaped mass, abdominal distension and tenderness. Some could have an additional signs like irritability, nausea, fever, and loss of appetite. The classical triad, you get a younger patient between 3 months to 3 years, coming with abdominal pain, passing a current jelly stool with vomiting. There are most likely chances that we are dealing with intussusception. On a physical exam of these patients, they will be lethargic with the colic pattern of abdominal pain. We could feel a mass in the right upper quadrant, which is sausage in shape. And when we palpate the right lower quadrant, there is absence of bowel contents in the right lower quadrant, which we call the dance sign. Then they may come with abdominal distension. When we do a digital rectal exam, we could find a blood tingled mucus or current jelly stool. Occasionally sometimes the intussusception can be failed. Some may come with the complications with the peritoneal signs if in case a perforation had occurred. And again, this is a drawing showing a young baby passing stool, which is blood stained, and we're seeing the red current jelly stool, which we find mostly into intussusception. So which other things could mimic these presentations in intussusception? We can have infections like gastroenteritis, enterocolitis. Could have immunologic conditions like the Henox Kleiner papilla. Could have a miscellaneous causes like appendicitis, Michel's diverticulum. They all present similarly to the intussusception. We could have incarcerated hernia, Crohn's disease, celiac disease. All those mimic intussusception. So which investigations can we do for these patients? We can do a full blood count, which may show a neutrophilia. In case we have peritonitis and we do a full blood count, we could see increase in the white blood cell count. Then when we do abdominal x-ray, it may show dilated gas-filled proximal bowel with a paucity of gas dismally and multiple fluid levels. When we do an ultrasound, it may show donut or target sign. It could also show a pseudokidney or sandwich appearance, and ultrasound will be our investigation of choice in intussusception. We could also do a bowel enema, which may show a crescent sign, may show a feeding defect, We could also opt for CT scan or MRI, which are more often used in adults as compared to children. And abdominal ultrasound, it has a high sensitivity between 98 to 100%, and the specificity being 88 to 100%. And again, this is what we can see. And abdominal ultrasound, intussusception are usually quite superficial masses which measure at 2.5 to 5 centimeters in diameter, and most are found in the right side of the abdomen. In the transversal section of the abdominal ultrasound, you could see concentric rings of tissue representing components of the bowel wall, and mesenteric fat are seen, sometimes referred to the donut or target sign, which we see in this drawing under here. What we mean by the donut sign, we could see a hypoechoic outer rim with a central hyperechoic core on transverse section. That's exactly what we are trying to see in this diagram. In the longitudinal section of the abdominal ultrasound scan, we could see pseudokidney. We see something that looks like a kidney under this longitudinal section of the abdominal ultrasound. When we do a plain X-ray, it may be normal sometimes. We could see Mink's sign. We could see crescent of gas within the colonic lumen that outlines the apex of intussusception. Little air in small intestines. And this is what we mean by the meniscus sign. That arrow weight showing shows a meniscus sign. There is a demarcation between air proximal and then fluid, which could show us that we have an obstruction somewhere. We could also do a barium enema, which shows coil spring appearance, trapping of barium between the edematous mucosal folds of the returning limb of intussusceptum and wall of the intussuscipium. Then still in the barium enema, we could see a meniscus sign. We could see a convex intraluminal mass. And the main contraindication of enema is perforation. So when patients come with complications of perforations, we don't do barium enemas. This is the coil spring appearance we could see when we use barium enema in these patients with intussusception. For treatment, we have to first stabilize these patients. We have to resuscitate them with IV fluids. We have to hydrate them. We have to make sure our electrolytes are in normal ranges, acid-base balance. We make sure patients are kept at nil per oath, and the stomach should be decompressed with a nasogastric tube. We give antibiotics in case there is any sign of infection. In case there is peritonitis, we could give ampicillin 50 milligrams per kg. It could be IM, it could be IV 4 times a day. We could also give gentamicin 5 milligrams per kg, IM or IV once a day. Then we could also give metronidazole 7.5 milligrams per kg intravenously 3 times a day. Management can be both non-operative, and we also have surgical management. In the non-operative treatment, we prefer this for stable patients with no evidence of bowel perforation, and should be treated with non-operative reduction. For non-operative reduction, we could use a hydrostatic or pneumatic pressure by enema, and the risk of perforation is more in the pneumatic technique. For the surgical treatment, this is indicated in case patients come with complications, patients come with perforations, come with peritonitis. We could first manual reduction at operation is attempted, and if this fails, or when a patients are presenting with perforations and necrosis or with a pathological lead point, we do a barrel resection and primary anastomosis. But the risk of recurrence is approximately 1% after manual reduction, meaning there is a high success rate when we do manual reduction. This is what we call the manual reduction. We just open up the abdomen, then we manually pull out the intussusceptum from the intussusception. We reduce them. The chances of recurrence are really very low, very low. This is a successful procedure. Possible complications, they typically do not occur within the first 24 hours. The possible complications could include intestinal ischemia, gastrointestinal bleeding, perforation, shock. Patients could come with the sepsis, dehydration. So we need to act as fast as possible. The more we delay, the worse the prognosis will be. So looking at the prognosis with treatment, intussusception has an excellent prognosis. The post-reduction recurrence radiologically is about 5%, and by use of surgery is about 1 to 4%. Looking at mortality, it's about 1% with the treatment, meaning when you treat appropriately within the shortest time as possible, most patients respond positively. And it is always fatal if untreated in 2 to 5 days. When we don't treat it, we have very bad outcomes. Thanks for listening.